As Ryan indicated, I'm Lance Hester. This is a session that we've called Downstream. If you were here earlier and you saw my talk about my story and Micah, it should serve as no surprise to have me repeat that Micah's not ambulatory. You saw him in his wheelchair. He hasn't been able to walk for 6 years, almost 7. And so this session's particularly interesting to me. It seems to be one that is will educate us on some of the promising therapies coming to relevance for our non-ambulatory boys. It's going to focus on myostatin, mitochondria, and fibrosis. And so, as we get started, the first of our panelists that I'm going to introduce is Roxana Dreghici. I got it? And she's here from Roche Genentech from Switzerland. Roxana.
Thank you so much, PPMD, for inviting us. It's very exciting to be here. I've been coming to these meetings in the last 5-6 years, and it's been getting bigger and bigger, and it's really exciting to be here. So my name is Roxana Dreghici. I'm representing Roche Genentech today, and I'm going to be talking to you about our anti-myostatin adnectin program in Duchenne. My disclaimer is that this session will contain general information about our Duchenne program and is not intended as specific medical advice. RG6206 is an investigational medicine that is still being studied in treatment of people with Duchenne muscular dystrophy and has not been approved by the US FDA, and the effectiveness and safety of RG6206 are currently being studied. You should talk with your healthcare provider for information and advice about your condition, including any current or potential treatments. A quick overview of my presentation today. So we're going to be talking about our molecule, what is RG6206, a quick overview of our clinical studies, and a status to date and next steps, and we will allow some time for questions. So what is RG6206? Myostatin, as most of you might know already, is a naturally occurring protein in the human body and is produced primarily in skeletal muscle cells. And its function is to actually stop the muscles from growing too big. We are investigating if blocking this pathway, blocking myostatin, could increase muscle growth and muscle strength in children with Duchenne muscular dystrophy. RG6206 is an investigational molecule that is being looked at for people with Duchenne muscular dystrophy. It's designed to bind myostatin and potentially limit its function and therefore possibly inducing muscle growth. And for the study protocol, RG6206, it's administered at home once weekly by subcutaneous injection, which is an injection under the skin into the abdomen area, thigh, or the back of the upper arms after initial training at the site to the parent or to whoever administers this medication. As I said, we're going to go quickly through our clinical studies for RG6206. Study 225, which is the purple first line in this slide, it was a study looking at the safety of our molecule, RG6206, in 103 healthy volunteers. This study has already been completed. Then study 226, which is the middle one, is a study looking at safety and tolerability of RG6206 in 43 ambulant boys with Duchenne muscular dystrophy. The recruitment of this study has already completed, and all patients are now in an open label extension. We actually have 41 patients still ongoing in this open label extension. And the last study, which is the blue bottom one, 227 study, also known as the Spitfire study, with its main purpose of looking at safety, tolerability, and efficacy of RG6206 in 159 ambulant boys with Duchenne. Just to present you a little bit what has happened in the phase 1b2 study, which was the middle one, the 2 to 6 study. So this was to assess the safety and tolerability of RG6206 in ambulant boys with Duchenne muscular dystrophy. The current status is that 43 patients were initially enrolled in the study. They were 5 to 10 years old. And they all participated in the double-blind part of the study, which was 24 weeks old, 24 weeks in length, and each patient received weekly a subcutaneous dose of RG6206 or placebo. This was a multiple increases subcutaneous dose study, and at the end of the 24 weeks double-blind period, all participants were offered to participate in the open label extension. And 41 patients are still ongoing in this extension study and receiving still weekly injections, which is now an open label 228-week extension study. Now I will focus on our ongoing phase 2-3 study, also known as the Spitfire study, which is assessing the safety, tolerability, and efficacy of RG6206 in ambulant boys with Duchenne. So in this study, there's a double-blind period of 48 weeks where patients will be randomly allocated to treatment. Neither the patient or the investigator will know if they are receiving the active treatment RG6206 or placebo. There are 2 doses of RG6206 that are being studied, and the randomization is a 2-to-1, meaning that twice as many people will receive active versus placebo treatment. At the end of these 48 weeks, the period which is double-blind, all patients will be offered to participate in the open-label extension of the study, which is 192 weeks in length. All participants will continue to receive corticosteroids for the entire trial. The planned number of patients is 159, and all DMD mutations are eligible to enter in this trial. So this is a distribution of the countries that are participating in the trial, and this is as of June 20th. There are 13 participating countries with 48 sites. If I'm not mistaken, I think 44 are actually active. There's 48 in total, 18 in US and 3 in Canada. We have sites in Japan, in Australia, and main countries in Europe. As of today, actually, we have already enrolled all the pre-planned 159 patients into the study, and there are a few patients that are still in the screening phase and will be randomized in the upcoming days. So as with all clinical research programs, we continue to monitor our studies to confirm if they should continue as planned, and we will be, of course, reviewing this ongoing Spitfire study at the end of this year. This review is pre-planned already by the study protocol, and it was not prompted by any event or monitoring trend, and we will be updating this community once this is complete. Again, reminding this is a double-blinded study, so it is important to keep it blinded in order to maintain its integrity, and as long as the study is ongoing, so there are still patients being treated in the study, the whole team at Roche Genentech that's involved in this study does not have access to any data, and therefore we cannot publicly share any data. So the study rationale and objectives of this study, the primary objective, as I mentioned already, is efficacy and to compare the change from baseline in the North Star total score after 48 weeks of treatment in the RG6206 treated patients versus placebo. The secondary objectives are to compare the changes from baseline at week 48 in those treated participants, looking at the 4-stair climb velocity, the stand from supine velocity, a 10-meter walk run, the PODCI, which is a pediatrics outcome instrument, proximal lower extremity flexor strength measured by manual myometry, the 6-minute walk test, the clinical global impression of change, and the stride velocity 95th percentile measured by Actimyo used at the ankle. I'm going to talk to you a little bit about this 95th percentile stride velocity, as I believe not all of you are aware of this endpoint. This is measured by the Actimio device, which is, was developed by Roche with some third companies, with our main focus to find another parameter or assessment that would capture better outcomes in Duchenne muscular dystrophy. So this is a wearable sensor that's worn by the boys at the ankle, and this is being investigated to see if we can record efficiently real-world ambulatory parameters. So we're looking at stride velocity, at the stride length, and the distance walked within 1 hour. So Actimio is being studied to detect different gait parameters and ambulatory capacity in a continuous manner. As we all know, clinical studies have visits that are, at 4 weeks or 6 weeks or 12 weeks, but it's really hard to capture activities that happen in between visits. So this is maybe one way of looking at things. So the stride velocity 95th percentile is a secondary endpoint which is being measured in a subset of ambulant boys with Duchenne in this phase 3 Spitfire study. Another thing that we are looking at is a caregiver video assessment, which is recorded through an application that is installed on the caregiver's smartphone. So the caregiver at home films 5 pre-specified tasks like sitting up, standing up, walking, running, and going up the stairs. And there's another extra caregiver choice task and new abilities that can be filmed. And this obviously allows recording of individual changes and functional abilities of the child in a real-world familiar environment. These videos are being reviewed and scored by independent blinded physical therapists to look at changes in the quality of the movement. I'm not really sure how we can play the video here, if needs to be from the back, because this is actually a video showing one of these video assessments. In this case, it's the task that's going up the stairs. So as you can, I don't know if the video actually plays. Can we try to, yes. So this is obviously an example from one of the patients that's not included in our study, has nothing to do with the ongoing program. And it's just an example of the task that the caregiver can film at home. This is then being sent, as I said, reviewed and scored by an independent physical therapist that looks at the changes in the quality of the movement. This allows the recording of individual changes and functional abilities of the child in a familiar environment at home, and thus reduces the potential stress associated with travel, an unfamiliar environment, and all other things that can be associated with traveling sometimes to a site that's not necessarily close to home. And this is just, I think, to show another example of a partnership where we focus with other companies on trying to capture better the patient perspective in order to develop new methods of capturing and quantifying change while we're treating these patients with Duchenne muscular dystrophy. I would like to thank you for inviting us to present here, and I would like to thank all the patients and all the families that have been enrolled in our program. This is an amazing community, and I'm really, really blessed to be here and present in front of you, and I think we'll have questions later on. Thank you.
Thank you. All right, thank you, Dr. Dreghici. Our next panelist and speaker is Dr. Kristina Nygren from Santhera.
Thank you very much for the invitation to come here and talk to you. Let me see if I can. So I will talk to you today about the clinical development program for idebenone. I will give some updates since I was here last year, and also I have some recent data to present. So first, let's take a look at respiratory function in DMD. And also I have to say, last year when I was here, I presented the same slide, and still there's no approved pharmacological therapy for treating respiratory decline in DMD, and that is something we want to change, of course. So increasing respiratory muscle weakness, it leads to decreased lung volumes and decreased airflow, and this means that the ability to cough and to clear mucus from the airways is decreased. And of course, this in turn leads to an increased risk of respiratory infections, pneumonias, and the like. And as the muscle function continues to decrease, there is increased risk of starting assisted ventilation. So natural history is a very important when we design our clinical studies, especially when we design studies in rare disease. This was also discussed yesterday in the clinical trial session. The graph that you see here is from the Synergy natural history data, and it has been very, very important for us to be able to understand our data and to design our studies. The graph that you see shows the decline in pulmonary function tests. So FVC is the blue line, and PEF, peak expiratory flow, the green line. And what you can see that when respiratory function has declined to 80%, it follows a linear trajectory down to approximately 20%. So this is very important when we design our studies. Also, the rate of decline is approximately 5 to 6% per year, and that's year on year. And the inclusion criteria for our studies now is 80% predicted of the lung function, and that's very important because then we know we have a linear decline of the respiratory function. Also, what the natural history data has shown us and learned us is that glucocorticoids, they delay the onset of the respiratory function decline. And this delay is approximately 2 to 3 years. But once the rate of decline has started at about 80%, the rate is similar as to those that you can see in the white bullets here in the graph that are naive or previous glucocorticoid users. They will have the same rate of declines as the glucocorticoid users. So this is also something we have learned from the natural history data, and this was very important when we designed the ongoing SIDRO study that I will tell you more about. So let's take a look at the clinical development plan for Idebenone or Puldysa, which will be the new name once we achieve an approval from the regulatory authorities. So I should mention that currently we do not have a regulatory approval for Idebenone. The development plan is aimed to treat respiratory dysfunction. Here is the clinical development program so far of Idebenone. We have conducted 2 placebo-controlled studies. The Delphi study was an exploratory study. The DELOS study was a placebo-controlled study in glucocorticoid non-users. We have finalized the 2 long-term follow-up studies, the Delphi extension and the SIRO study, that I will tell you a little bit more about. And finally, we have the SIDRO study. That's also a placebo-controlled study in glucocorticoid users that is ongoing. And after that study, we plan to enroll patients into an extension phase. So the DELOS, the completed phase 3 study, you probably have heard about it. We enrolled 64 males with DMD, and 92% were no longer able to walk. The study was conducted in 17 centers in Europe and in Asia, and the treatment duration was 52 weeks. So the data from the placebo-controlled DELOS study has been extensively published. The study met its primary endpoint, the peak expiratory flow, PEF% predicted, that was statistically significant compared to placebo. And also the graph to the right, you can see the home-based assessment of PEF% predicted. The yellow line is the Idebenone treated patients and the decline, and you see there's a significant difference versus the placebo-treated patients, that's the gray line. In addition to a positive primary endpoint, we also saw a consistent treatment effect for other respiratory function measures, such as inspiratory flow reserve and also the FVC, the forced vital capacity. In addition to seeing effect on the respiratory measurements, we could also see that idebenone reduced the risk for bronchopulmonary adverse events such as airway infections, pneumonias, bronchitis, and such. Also, the need for systemic antibiotic treatments and the risk for hospitalizations due to respiratory complications was decreased. So, what does it mean to have a change in the rate of respiratory function decline? Well, we have analyzed, there's been an analysis done by data from the Synergy study again. Here we looked at the time from crossing 50% of PEF, that's the graph to the left, and FVC, that's the graph to the right. And you can see those that had slower decline, that's the blue line. The decline was slower than 5%, which is the average in the natural history. And the red line is those that had a faster decline of PEF or FVC. We could see that there was a difference of 3 years to needing assisted ventilation. So this data shows us that the rate of change in PEF or FVC can predict the time to reaching a clinically relevant milestone. So the DELO study showed significant results in the 12 months setting. So now the question has been, what happens after treatment in a longer duration? So what we have done is analyzed data in a prospective manner. That means we wrote a study protocol and retrospectively collected data for patients that had received idebenone after the DELO study. Not all patients could receive idebenone after the DELO study, only in countries where expanded access programs were available. So this data became recently available. It has been presented, and we are waiting for this data to be published. So after the DELO study, we had a period, that's the red box, where patients did not receive idebenone. This was a mean of 1.2 years. And after this period, patients did receive treatment with idebenone, and this treatment lasted for up to 6 years, on average 4.2 years. So this is, as far as I know, the longest duration of a DMD study. So this shows results of the evolution of the respiratory function decline. The yellow bar, that is the idebenone treatment, and the gray bar on the first year, 1 to 2, is the period when patients did not receive idebenone. So there's a clear difference here. Also, when we matched the idebenone-treated patients with a control group from the Synergy, we could see a persistent in effect, and that lasted as long as the study duration, up to 6 years of treatment. In addition, in the ZERO study, we did also see a reduced risk of bronchopulmonary adverse events such as pneumonias and other upper airway infections, and that was the same pattern as we saw in the DELOS study. So let's take a look at the ZERO study. The study is ongoing and recruiting at the moment. It's the largest ongoing clinical study in DMD, and the aim is to enroll 266 patients. So as with all DMD studies almost, recruitment is challenging. We have been recruiting patients for some time, and we expect to finalize the study during the fall, but we need some 40 to 50 more patients to be able to finalize the study. In this study, we enroll both ambulant and non-ambulant patients. Patients of all mutation types are welcome, and all those patients that finalize the ZERO study will be rolled over to an extension, open label phase. So the SIDRO study is actually the third placebo-controlled study in Santhera's development for idebenone. Patients will be randomized to receive idebenone or placebo for a duration of 18 years. The key inclusion criteria is boys should be 10 years or older. They should have a chronic use of systemic glucocorticoids, and the respiratory function should be in decline, as shown in the natural history graph that the respiratory function should be below 80%. The primary endpoint is change in FVC from baseline to week 78. And of course, we have a number of secondary endpoints. So I think I have mentioned most of the key inclusion criteria, but I just want to emphasize that, again, we are looking for patients with an FVC between 80 and 35% to start the study. The FVC values need to be reliable between screening and baseline. And in addition, we need immunizations to be done at baseline. So we have approximately 66 clinical trial sites in US, Europe, and Israel. You can find more information in sidrosdmd.com. There is in the glitter bag, there's some more information, and also the Santhera team, they are here to answer all questions you may have about the study. So why do we need to do the SIDRO study? Well, it is something we have been discussing with FDA and agreed that the SIDRO study is needed for us to be able to submit the dossier. So once we have finalized the study and we have the data, we will submit the dossier to FDA, and hopefully we will receive full approval for all boys with DMD regardless of steroid use. So that depends on the data. For Europe, recently, maybe you have seen, we submitted a dossier just some weeks ago. The dossier is based on the DELO study, but we also have added the new data from the long-term real-world SIRO study. We have more natural history data that helps us explain the clinical relevance of the data from our placebo-controlled studies. We are seeking a conditional marketing authorization in Europe, and the SIDRO study will later help us expand the label to also patients that are using steroids. So again, it depends on the data. So to summarize, treating respiratory function is an unmet medical need. The DELOS and SIRO studies shows that idebenone can slow the decline of respiratory function, also in the long-term setting. The natural history data is important and shows the clinical relevance of slowing the decline in respiratory function. And SIDROS will support the regulatory submissions in US and in Europe. And hopefully the enrollment will be completed during this year. And so I would like to thank you all, the patients, the carers, the community, and all of you to participate in our trial. So thank you so very, very much. Thank you.
Thank you, Dr. Nygren. I just received notice we're not going to be hearing from Capricor today. And I will now be introducing from FibroGen. I think Ken Lipson's going to start us off, and then Bassem Elmankabadi is going to be following up.
Hello, everyone. So today I'm going to introduce you to our target, CTGF, our inhibitor, pamrevlimab, and then my colleague, Bassem Elmankabadi, who will tell you about the clinical trial that we've been doing, phase 2 clinical trial, and share with you some of the data from the preliminary analysis after 1 year of treatment. So we'll start with the inhibitor. Pamrevlimab is a human antibody. It binds to a protein called CTGF, connective tissue growth factor, and it inhibits its function. And I'll tell you more about CTGF in a minute. So we have been testing pamrevlimab in clinical trials for treatment of idiopathic pulmonary fibrosis and locally advanced pancreatic cancer. It's shown promising activity in those indications and is now proceeding on to phase 3 clinical trials. We've been testing it in non-ambulant DMD patients, and we're in a phase 2 clinical trial and planning for the phase 3. So CTGF, as I said, it's an acronym. It stands for Connective Tissue Growth Factor, but it's very important to understand that it's not actually a growth factor. It's a regulatory protein. It's secreted from cells, and it modulates how cells recognize and respond to their environment. Now, I'm talking to you about it because it's induced by many different factors and conditions that are associated with many different diseases. And when it becomes overexpressed, pardon me, when it becomes overexpressed, it promotes the formation and activation of myofibroblasts. Myofibroblasts are the cells that lay down extracellular matrix and lead to tissue remodeling, which in turn leads to fibrosis or aberrant scar formation. Now, if that remodeling occurs in the vasculature and the blood vessels, then it can create local hypertension or high blood pressure locally. That leads to more CTGF expression, and so here's a positive feedback loop that can lead to the progressive nature of fibrosis. There are other positive feedback loops as well. So TGF-beta and VEGF are other factors that promote the expression of CTGF, but CTGF in turn promotes their expression. And so there are multiple positive feedback loops with CTGF in the center. And our goal with inhibiting it with pamrevlumab is to break these positive feedback loops, and by doing that, stop the progressive nature of fibrosis. Now, what's shown on this slide is a cartoon of normal wound healing on the left, the mostly circle, and then on the right, what is a branch off of that leading to fibrotic repair. So when a tissue is damaged, then it starts a cascade of events that lead to restoration of the normal tissue structure and function. In the case of DMD, the damage occurs just by using the muscles because of the disconnection between the inside and the outside. When damage is chronic, it leads to persistent activation of myofibroblasts. It leads to the excessive deposition of the extracellular matrix proteins like collagen and fibronectin, and it leads to scar formation or fibrosis. And you see their CTGF in red, you see all the arrows going back and forth. That's where all of those positive feedback loops are happening. And so what we're trying to do with pamrevlumab is to block those feedback loops and to push the tissue back into a normal wound healing process. That's shown in the green dotted line. Okay, so now I'm going to turn over the podium to Bassem, who's going to tell you about the phase 2 clinical trial that we've been running.
Thank you. My name is Bassem Elmankabadi. I'm a board-certified surgeon. I'm leading the program for Duchenne muscular dystrophy in FibroGen. So as you see here in this slide, actually we have a study called 079 study. It's an open-label, single-arm, phase 2 study targeting only non-ambulatory patients with Duchenne. The safety measured by a central lab in addition to a central radiologist to read our MRI parameters in this study, which I'm going to go through it in details. To date, we have 21 patients enrolled in the trial, and our interim results conducted after all patients completed the 52 weeks of treatment of pamrevlumab infused 35 milligram per kilogram biweekly. So this is just a brief summary of the demographic and baseline characteristic of our trial in non-ambulatory patients. The key points here, all the median age of the diagnosis of as a Duchenne patient is around 5.5 years, and also time to be non-ambulatory was almost around 3.5 years from the time they enrolled in the trial. All subjects are in corticosteroids, whether deflazacort or prednisone. So safety. So pamrevlumab appears to be very well tolerated, actually in pediatric patients in non-ambulatory Duchenne muscular dystrophy. The most common treatment emergent adverse event as shown here were mild, moderate, grade 1 to 2, and also no treatment emergent adverse event led to discontinuation of the trial or pamrevlumab. So SE, the same concept, appears here, no safety concern. Efficacy, I divided the efficacy actually into 3 parameters: pulmonary function, cardiac function, muscle function. So we'll start with the pulmonary function as a leading cause of morbidity in this population in Duchenne muscular dystrophy. We test pulmonary function test in 3 parameters: forced vital capacity, percent predicted, forced expiratory volume at 1 second, and peak expiratory flow rate. Pamrevlumab achieved positive results with data showing that less disease progression, that mean better preserve of lung function compared to the published data from previous study on the natural disease history, Ricotti and Mayer. I'm going to go in details in each parameter now. So forced vital capacity percent predicted, as you can see here, in a study 079, the mean percent predicted from baseline was around 54%. Median is around the same, 54%. Ricotti paper showed the baseline actually was 62. At 1 year, better maintenance of lung function was observed in a study 079 with less decline in percent predicted forced vital capacity than the observed previously published data in Ricotti. And you can see that the baseline, our patient came with less percent predicted forced vital capacity than the population measured by Ricotti. So expiratory volume at 1 second, the same concept. Study 79, the baseline was around 54%, median was around 55%. In the last study, placebo arm, the mean was the same kind of like 079 study. So at 1 year, pamrevlumab showed improved maintenance or less decline actually in forced expiratory volume than what's seen in this published paper by Mayer. So third parameter is the peak expiratory flow rate, very important parameters that can lead to the assisted ventilation down in the road with this inability to cough and clear the airway in this population. Therefore, we paid attention here to test this very diligently. In a study 079, the mean baseline was 55%, median was around 52%. We compared it to Ricotti, the mean was around 65%. So the same concept here, consistency with the other, our patient and the trials are a little bit in the worst side from pulmonary function standpoint. A 1 year treatment in pamrevlumab appears to result a slowing or in the decline in the peak expiratory flow rate compared to what observed in Ricotti. Efficacy, cardiac parameter, very important parameter, most common cause of the mortality in this population. So we paid attention actually in FibroGen to test this diligently. We did use a central radiologist, and we used MRI, cardiac MRI, and late gadolinium enhancement to measure the cardiac fibrosis scar burden on the heart. There was actually very encouraging result in 079, suggested that the actual improvement in a specific measurement of the cardiac function achieved by the treatment of pamrevlumab infused biweekly compared to what's published by McDonald. So I'll go in details in the cardiac parameter as it's an important aspect in our trial here. Ejection fraction, as you can see, ejection fraction in usually these patients decline around 1% annually. We did an analysis showing after our baseline, actually the patient came to the study with an ejection fraction around 55%. However, in McDonald patient, the baseline was a little bit higher than that. So we did divide the ejection fraction into 2 categories, ejection fraction more than 50 and less than 50. So the results showed that an estimated mean change was an increase instead of decline in ejection fraction of 0.29% And the subgroup analysis showed an increasement in the patient who comes more healthier to the study, which ejection fraction is above 50 to almost 1.8% in plus. So cardiac fibrosis, we didn't take it lightly here, so we did the gadolinium enhancement, scar burden on the heart. We measured by MRI central radiologist. As I said earlier, we found a very nice correlation at week 52 between the improvement in ejection fraction and the reduction in the cardiac fibrosis observed by the MRI. And that's consistent exactly what was published by Tandon paper and results. The results showed a stabilization or possible improvement in the myocardial fibrosis in this patient who received pamrevlumab. So then we looked at the muscle. We looked at two parameters, same thing, upper muscle, upper arm function, wise up pull score, because that gives our patients inability to function independent. Actually, we found it actually it's very helpful for our patient. Therefore, we did test the pull total score, and we correlated that with an MRI for the biceps muscles to make sure that we're not missing anything here. So, and we also looked at the handheld myometry to test the grip strength in our patient. So pamrevlumab showed positive results preserving the upper arm function, either improvement or delayed decline in the loss of the upper arm function. And we're going to go in details in a second. Pull total score. In study 079, mean score was around 24, and the median was around 22. Ricotti study was 50. So our patient, the same concept applied here. Our patient was a little bit weaker than the published paper. In study 079, the mean change from baseline was minus 1.53 compared to what's published in Ricotti paper, which is minus 4.13. So way much better. So upper arm biceps brachii, fat, MRI, T2 mapping actually to indicate the edema and the degree of the edema and inflammation in the muscle showed that in strong correlation between the change from baseline to week 52 in the biceps T2 mapping MRI with the change of the pull total score. The result demonstrated a stabilization or even possible improvement in the muscle fibrosis burden. Grip. We test the handheld myometry, use the handheld myometry for the grip. In study 079, same concept to apply here. Mean grip strength score at baseline was around 45 Newton, and in the dominant hand around 41 in the non-dominant hands. Bottom line, 079 showed a positive increase in grip strength score in both dominant and non-dominant hands over 1 year of treatment with pamrevlumab. With earlier results, strength score was better than the published paper with Siferian. So this is a slide showing that we have an open label trial study. A number is too small, so please use this data with cautious. Conclusion. Preliminary result for 079 showed 1 year of pamrevlumab in non-ambulatory subject with Duchenne was very well tolerated actually. Treatment emergent adverse event occurred and were mild to moderate, no safety concern to date. Pulmonary function assessed by forced vital capacity, peak expiratory flow rate and expiratory volume, forced expiratory volume in 1 second showed better result and less decline in expected by the disease progression. Cardiac fibrosis, cardiac function results showed an MRI improvement in the mean ejection fraction compared to what's published by McDonald. A correlation between the improvement in ejection fraction and the reduction in the cardiac fibrosis, very outstanding. Perform an upper arm strength showed also a less decline in the pull total score compared to what's published out there. A strong correlation between the change in the T2 mapping for the biceps and the improvement in the total pull score. So therefore, overall, pamrevlumab was very well tolerated, showed good promising results in terms of slowing down the disease progression across all study parameters of the disease compared to the published paper. And on behalf of FibroGen, I want to thank the patient, the Duchenne muscular dystrophy patient, the caregiver, the moms, the dads. We are here to serve you. We will going to make our best effort for us to serve you, actually, to find a treatment for you guys. And thank you for PPMD, actually, to invite us. Pleasure, Pat. Thank you again for allowing FibroGen to present. Thank you.
Thank you. You know, we're going to open this up for questions, and that will be followed by polling. I guess maybe a quick question in case maybe it wasn't covered or you missed it. Maybe I could just ask each of the panelists real quickly how their therapy is administered. Could I start with you?
Yes. Ours is administered weekly subcutaneous injection at home by the caregivers.
And at home? Yes. Okay. And
It's oral administration.
oral. And for how frequently are the site visits?
The site visits in the study?
In the study, yeah.
Yeah, so every 6 months.
Okay. Same questions.
Before I answer the question, I'm Elias Khashoggi. I had the clinical development for this program at FibroGen. This is monoclonal antibody is infused every 2 weeks at 35 mg per kilogram.
Okay, thank you. Okay, questions? And if you could say who you are and if you have a loved one with Duchenne, if you could say their name as well.
Okay, hi, my name is Dana Edwards, and my son is Tanner, and he is in the FibroGen trial. I'd come up there and kiss you guys if I could. I want you to know that my son is a different, he's a different kid than when I enrolled him in the trial. He's a kid again. His weight loss, I'm your biggest fan. And I mean, I got in by the grace of God, and it just all went well for us, and I help with recruiting any way I can, but I would like to see if you guys would look into veins, because I'm noticing my son's veins are back, where you couldn't get to his veins, so we were about to put the port in, but now it's 1, 2, 3, we're back to a regular nurse just coming up and drawing his blood. I've noticed that. We need the pillows for the MRIs for the boys, because the MRI is a little bit long, and the guy that presented it last time said he was going to have the pillows. And then there was one other thing I wanted to ask you. Home care. When are you going to come to my house?
Thank you, first of all, for having your child in our
Oh, you were the
study.
one that was here the
I'm
last
one
time.
who
I'm
was here,
sorry.
Of course. Starting by saying, looking at the veins, I think as Ken can answer this better than me. We have done a preclinical testing, and we know that we will improve on the vascular health in general. Would you like to comment on this?
Sure. So we haven't looked specifically in a DMD animal model regarding the veins, but we have looked in complications of diabetes models, where one of the complications is vascular remodeling. And we can actually show reversal of remodeling in that model. So yes, the CTGF is definitely involved in vascular remodeling, and it's encouraging to hear that.
It is, and I know another family that's in that same thing happened to them. They were just like us, about to go for the port, and then, you know, we did the ultrasound IV, going deep into it's tough to have a little boy sit there and go through that, but now it's back and it's amazing.
And I'm going to add the clinical aspect here. Actually, maybe most likely, and as a clinician, could be the weight change and the veins start to appear. The edema, the less of the edema, the water collection is less, so the ability to find the vein is a little bit better. Overall, that's a good sign.
Yes.
About home care.
Home care.
We are looking into to have this, and now we have this long use of the product into home infusion. So we are in the process of evaluating this, and even the patients who are in this study in 079 will, if they prefer to receive the infusion at home, we will be able to provide it.
That'd be amazing. Thank you so much.
Thank you.
I appreciate everything, and thank you for bringing my son back. It's awesome.
Thank you. We'll move to the other side of the room.
Hi, my name is Colin Worth. I'm 24 years old, and I'm on the PPMD Adult Advisory Committee. I had some questions for Santhera. My first one was if you had considered doing any studies between the difference of CoQ10 and idebenone. And the second question was if you've considered doing any measurements for muscle strength or any other, or even heart muscle.
Much for the questions. So with regards to the difference between CoQ10 and idebenone, there's currently no plans to do any studies, but we are looking into be able to better explain the difference with the use of preclinical work and published data. So there will be more resources available to be able to see the difference between CoQ10 and idebenone. And the second question was
regarding testing whether it's
yes.
affecting other muscles.
Yes. So currently in the CIDRO study, we are mainly focusing on respiratory function, but we are discussing with regulators to do maybe more studies, since we have submitted and asked for a conditional marketing authorization. So if we were to do another study, we would definitely add looking into muscle function as well. So, but it's a little bit under discussion at the moment, so I cannot answer in detail, but thank you for the questions.
Okay, thank you so much. I really appreciate all the work you're doing.
Thank you very much.
Thank you, Dr. Nygren. Thank you, Colin. Okay, and back to the other side of the room, the original side.
Hi, I'm Vicky Castillo, and my son is Patrick. He's 10 years old, and he's in the Spitfire study. So this question is for Roche. You haven't released any results at this point, I believe, from the second arm of your study, the one with the 41 boys, and I'm wondering when we might expect some results from that study.
So your question is regarding our phase 1b study, the one. So that study has completed in the 24-week period, which was the double blind, and all the 41 boys are now in the open label. This is again a study that was for safety and tolerability, so it had no efficacy as primary objective, and there is some data published out there on mainly safety and tolerability.
But nothing on the results of the study.
So there was a exploratory secondary look at some efficacy endpoints, but of course, being such a small study, it was not powered for efficacy, so the data was inconclusive in that matter for efficacy, because it was a small number of patients and it was not powered for safety. For efficacy, it was just safety. But the data will come up from the phase 3 large study.
And when will you expect to
So
be able to release
enrollment has completed. 159 patients are already randomized into the study. There are a few other patients being randomized in the next upcoming days. And when they will complete the 48 weeks of treatment, obviously we will have results. So that's going to be later, towards next year probably.
So a year, they have to be in it?
Yes,
A year
that's
from
the 48-week double-blind period.
Okay, thank you.
You're welcome. Thank you.
Thank you. And Julie.
Can I start?
Yes.
My question is for Santhera, and then I have one for FibroGen after. But Santhera, are you able to do compassionate use for the older ones?
So thank you for your question. We have in the US an expanded access program available. So there's more information available to what sites that have enrolled into this study, but definitely it is possible via the expanded access program.
And how soon do you anticipate that idebenone, or the new name, that it would be available for all in terms of, getting FDA approval? What's the timeline?
Yeah, so we need the CIDRO study. As I mentioned, it's still ongoing. We plan to finalize it end of the year, and then it's 18 months treatment. So that's 2020. So will have top-line results by 2021, and then we submit to FDA, and it depends on the process there. So it will take some additional years, 3 years maybe.
And then my next question is for FibroGen, and I want to thank you. My son is 27 in your clinical trial at UCSF, and I appreciate all you up there. As parents, we're so grateful for any opportunity for our children, and just waiting for the opportunities to open up to others as well. FibroGen, are you considering in any other sites, like at UC Davis, to give expand?
So we are in the process of discussing our next step. What is our pivotal study is going to look like? At that time, we have to increase the number of sites tremendously. As we've seen of our colleagues in our, developing this product, have to open more than 10 sites to be able to enroll the study. We know the difficulty of enrollment, and we will be considering UC Davis and all other major centers in the US. We will be this time going globally, and we will consider a center in Europe at the same time.
I really want to thank you for all that you're doing for our children, and you've been very generous for those in the clinical trial, and UCSF has been outstanding. And I want to thank everyone here. It's much appreciated. Thank you.
Thank you.
And this is a good time to thank all of our panelists and our questioners. And Ryan's coming up for some polling. Stay. No lunch. Those doors are locked. The doors are locked in back.
It's only a few questions, I promise you. Okay. Thank you to those who have stayed. We can get our first question up. There's only 3 for this, and then we're going to release you to eat. Go ahead and pull that first question. Should be how far do you currently travel for your semi or annual comprehensive Duchenne or Becker care visits? Very interested in knowing how far people may have to travel, whether or not they're traveling to a certified clinic or not. Seeing about a 1 to 3 hours. Seeing some close by clinics, which is always good to see, but still some that are traveling much farther. Let those results come in for a minute. Okay. Looks like we're getting some numbers still coming in. I just want to make sure they're all in. Still some high numbers for those more than 10 hours. Okay. Next question. This is for those participating in a clinical trial. How far do you travel for your study visits? Study visits would most likely be your assessments. Those are those longer appointments. Okay. The one way. I would say one way. Yeah. In about 1 to 3 hours. Hopefully we're getting more and more sites that are close to people. It's always a challenge with clinical trials. Still see some more than 10 hours, which is certainly a burden, and that 3 to 5 hours, it's not quick, it's not around the corner. Okay. Last question is for those who are 10 years and older. We're interested in understanding when the last time you saw your pulmonologist was. Good to see them on that top layer. For those who answered the age question earlier yesterday, if you were in here, we'll be able to stratify by some of that exact ages. Some have never seen. last year, majority in the past 6 months, which is good, or in the last 3 months. High numbers in the last 9 months alone. Okay, I really, really appreciate you all taking the polling. You are released, and you'll see me up here again. Take care.